So I'm going to actually take a moment because how long do I have? How long should I try to make the talk? Because I want to take a little bit of a choose your own adventure approach here and tell you what I have in this talk. And I'd love to hear from you, since we're a small group, what would be most interesting for me to spend more or less time on. Okay, so this talk is on economic evaluations and implementation research. So you hear stories about people's half an hour? Okay, okay, I think I can do it. Paths are interesting in your career, and I feel like my coming to include economic evaluation in my work has been a really interesting thing for me because my undergraduate degree was in economics. And when I went to medical school, I thought I was leaving that all behind me and imagined myself becoming a clinician who never did anything with my economics degree. But my research has sort of led me back, and it's been such a pleasure to get into this space. The agenda that I had for this talk is to cover the basics of economic evaluation, and then to cover cost effectiveness analysis and budget impact analysis in a little bit more depth, as well as getting into methods for costing interventions. In response to some of the earlier comments, I actually added some slides to talk a little bit more of applied cases from my own work and how I've used those cases towards policy advocacy. So I'm also happy to kind of get into that. I'm curious, could I get a sense from the group? Did you guys have thoughts about what we should focus on today in terms of things you'd be interested in out of this agenda? I'm happy to spend more or less time on any of those things. Uh-huh.
What is the difference between economic evaluation and cost effectiveness?
So economic evaluation is the broader umbrella. So maybe I'll explain that and then come back to the question, because maybe the first couple of slides will give you a sense of that. I wanted to just quickly start with why. Why do we do this? So our ultimate goal is to improve health and quality of life, right? How do we do that? We try to translate evidence-based interventions into practice faster. But what gets in the way, right? Lack of evidence is typically what we all think as researchers. If we just have more evidence, things will get into practice faster. And the question, and I'm so sorry I don't remember your name, but the question you asked earlier over here kind of highlighted that I think the message we're sending is that generating more evidence is going to accelerate dissemination. I hope no one leaves with that message, because the key is the lack of the right evidence that matters to decision makers, not just you and your colleagues, and the effective dissemination of that evidence, I think, is really what gets in the way. And so just generating evidence for the things that are compelling to us as researchers who sometimes get really interested in nuance doesn't always translate into more rapid dissemination and implementation. So this was really in response to your comment. I'm sorry that I didn't get your name. So exploring the mind of a healthcare decision maker, the folks that are changing policy, the folks that are deciding, am I going to implement this intervention in my hospital system or my healthcare system? They're thinking about which health outcomes matter most. Is this health outcome prevalent? Is it impactful? What resources do I have? Which interventions are effective in real world settings, not just in kind of idealized settings? What is their reach and impact on inequities? How do we implement and sustain them? How much will it cost to implement these interventions in the short and in the long term? Sometimes interventions have a lot of startup costs, but then they're cheap to maintain. How does this compare with existing interventions we already pay for and or other alternatives we could consider? Is the incremental benefit enough to justify the additional costs required to adopt the intervention? So these are really practical, salient questions that might be different from the research questions that your team is focused on. So kind of making connections to what matters most to healthcare decision makers, I think, is really critical. So economic evaluation methods speak directly to those information needs. They can compare multiple interventions simultaneously to estimate which interventions provide the greatest value. They can assess different time horizons. For example, what are the expected costs and benefit over 1 month versus 10 years or lifetime? The methods differ based on how consequences are defined. And so we can get into that, but specifically I'm going to focus on cost effectiveness analysis, which folks hopefully have heard of. You might have also heard of cost utility analysis, and then you probably also heard of cost benefit analysis. And all the time you'll hear people using these terms as though they're interchangeable, but they're actually slightly different. And so hopefully you'll walk away with a sense of that. Yes. I'll chat about that. Okay, so what is a cost effectiveness analysis? So it's most useful when you're considering a limited range of options within a given clinical field. For example, I want to compare intervention X to intervention Y, and I want to assess what are the cost trade-offs and the benefit trade-offs between interventions. So for examples, as examples of potential effectiveness measures, so for thinking about the treatment of hypertension, your effectiveness measure might be blood pressure reduction, and you might assess your ratio would be like cost per unit reduction in blood pressure. Asthma might be episode-free days. For HIV, it might be AIDS-free life years. For colorectal cancer, it might be cases detected. And so when your denominator of that cost effectiveness ratio is something like a unit of health or a unit of care improvement, then you're limited in your comparisons across those interventions within that column. But often your healthcare decision makers are not focused on just one disease model. They're often interested in multiple conditions or outcomes. So that's when you get into other kind of methods. And I want to say, so cost utility analysis is a type of cost effectiveness analysis, and people will use the term interchangeably, that allows for broad comparisons across widely differing programs. So effectiveness measures become a composite of a summary outcome. So are folks familiar with the term QALY or DALY? Yes, some folks, yes. So QALY stands for quality adjusted life year. So it's essentially the quality of life experienced for each extra year of life. So it's sort of, we talked earlier about mortality not really giving us the full picture. When we add in quality of life to that, we get more information about value. DALYs are sort of the corollary of that. It's the disability adjusted life years. So it's, we could have a whole separate day talking about how we get to these measures. There are different approaches. I'm just going to skip over that, but happy to chat offline about it. Cost benefit analysis is sort of a different thing. So it requires program consequences to be valued in monetary units. The primary goal of cost benefit analysis is to identify projects with positive net social benefit. And the equation's there, but essentially, instead of saying the cost per QALY is this, you're actually trying to translate the QALY into a monetary value so that you can kind of get to a more concrete conclusion. But obviously, that's difficult to do. So how do you assign a monetary value to a health outcome, such as a year of life or an HIV diagnosis? So this approach is much less commonly used, the cost benefit analysis. And it's sort of a pet peeve of mine that people use the term cost benefit analysis a lot when they really mean cost effectiveness analysis. So this you'll get all the time if you get into the space of economic evaluation. People will ask you, well, is it cost effective? And reviewers of papers and editors of journals often want you to be able to say, is the intervention cost effective? And so I'm going to convince you to resist that a little bit. Whether or not an intervention is cost effective is only relevant in context, unless it's cost saving. So you have to be clear about what you're comparing to be able, or comparing with, I should say, if you're going to make a statement about cost effectiveness. So if you're comparing to status quo, your intervention should be cost effective compared with status quo. Or not cost effective compared with status quo. Is that additional dollar I'm spending, is that translating to an additional unit of health that meets my willingness to pay threshold above status quo, then I can call it cost effective. Just throwing out the term cost effective without context is a danger and can be misleading. So you have to have some point of comparison. It could be that it's more cost effective than what we're currently doing, some other intervention, or society's kind of set willingness to pay, which in Europe, you guys actually have some thresholds for willingness to pay. In the US, we don't really have set thresholds. And so tools that help facilitate that type of communication, those comparisons, are things like incremental cost effectiveness ratios, which is, taking that cost over quality or whatever your effectiveness measure is, and subtracting out the cost per quality of the next best thing you could do, and just focusing on that increment. And then cost effectiveness planes, which I'll show you. This is an equation that's very simple for a incremental cost effectiveness ratio, or ICER. It's essentially just cost of the intervention minus cost of your next best option divided by the benefit of the effect of the intervention minus the effect of your next best comparison. So very simple. Cost effectiveness planes, anyone seen these before? Okay, I'll take a second because I think this is worth being familiar with. So on the y-axis, you have the difference in cost. And on the x-axis, you have the difference in effectiveness. And so basically, you just sort of you put a pin in the spot where your costs fall and your effectiveness falls. And ideally, you're comparing multiple things. And so you'll be able to sort of comparatively say, if something falls into the top right quadrant, it's higher costs, but a better outcome. If it's in the top left quadrant, it's higher cost and a worse outcome. That's never where you want to be. And then the bottom left is lower costs and a worse outcome. Hopefully we don't want to be there, but in some cases, you might have to make that choice because of constrained budgets. The ideal quadrant is the lower cost, better outcome quadrant. And so usually what folks will do is the zero, the cross point, is your status quo. And then all of your interventions get pinned, and it's a incremental cost and incremental effect compared with status quo. So decision-making using cost effectiveness, this is just an example of a completed cost effectiveness plane. As I said, the origin is your no action option, your status quo, or your usual care. And then we talked about the axes already. Does this make sense and clear how to use these tools? Okay, and so here's an example of, I'm gonna, in the interest of time, I'm gonna skip this because I think this is pretty intuitive, and raise your hand if anyone wants to spend a little bit more time on, yeah, you'd like to spend a little more time. Okay, all right, so to choose the optimal strategy, we first eliminate the what's called dominated strategy. So that's where it costs more, but produces less or equal effectiveness than at least one other strategy on this plane. So an example of that is O dominated by E and H dominated by I on this plane. Or you can also, another approach is to sort of draw a line connecting two other strategies. So F is dominated by O and G on this plane. So these slides will be available to you so you guys can spend a little time looking through that. And then the cost effectiveness frontier represents a line you draw across all the non-dominated strategies that sort of remain once you've eliminated the dominated strategies. Okay, so limitations of cost effectiveness analysis and implementation research. So CEA provides info on long-term economic benefit, but usually doesn't address implementation costs. Costs is a notable barrier to implementing evidence-based interventions. And intervention implementation costs, for example, labor, materials, technical assistance, are often more important to policymakers and organizational leaders than effectiveness. So let's spend just a second on that. And budget impact analysis is another approach that is not kind of considered in the same column as cost effectiveness analysis, cost utility analysis, or cost benefit analysis, but it's much more of like a descriptive approach that's trying to tell a decision maker, how much is it going to cost to do this thing? What's the impact on my budget going to be? So it's you're assessing expected short-term changes in expenditures for a healthcare organization or healthcare system after adopting a new intervention. Like, what are my acute costs? Like, what do I need to pull together to be able to implement this? Provides essential information for healthcare administrators and payers about the affordability of an intervention. And the results can be used for budget and resource planning. So this can sometimes be a very practical approach. People do publish papers on budget impact analysis, and it can be helpful. Comparing the kind of two approaches, the budget impact analysis doesn't require comparison intervention. It typically involves comparison to existing practice. And it doesn't require effectiveness data. So this sometimes in our larger trials, often it can be a while before you really have data on your trial outcomes and data on cost effectiveness. Often that's like at the end, like in year 5 of your 5-year grant, you finally have the data to be able to do a cost effectiveness analysis. But in terms of like incremental product, you can kind of share with the scientific community. A budget impact analysis can be sort of a helpful output. Both should be conducted when reasonable evidence of potential efficacy or effectiveness of an intervention exists. Yes. Yeah. Mm-hmm. That's such a good question. Yes, so MRI is a tool that we have really good evidence for as a useful, effective tool. So budget impact analysis is a great approach for a health system. You probably wouldn't necessarily publish that, but in terms of like a practical look at what's my immediate cost to get this into my health system, budget impact analysis would definitely be the way to go. The cost effectiveness analysis version of that would be so complicated to get from buying an MRI for one health system and what's the impact of that on quality adjusted life years. That would be a super complex model and probably not the way you'd want to go. I'm going to make the decision to just jump over this and have this be a reference for you guys to read more about budget impact analysis, because I kind of think the rest of the talk might be more interesting to you. Costing, well, I'll ask you, would you guys like to spend a little more time on budget impact analysis, or kind of get into how do we actually assess costs of an intervention? Okay, good. All right, so generally people think of kind of 2 big ways to assess costs. There's gross costing and micro costing. In general, we think about kind of enhancing generalizability and usefulness and assessing uncertainty when we think about estimating costs are kind of the 2 big things there. So what do I mean specifically? So when we talk about enhancing generalizability and translatability of our cost estimates, it's very, very important for us to be, if you take away just a couple of things from this talk, this is one of them, whenever doing a cost study, you have to be crystal clear about the perspective you're taking in estimating costs. So you don't want to just say this, this cost X, because the costs are going to differ based on who you are. Are you, someone in a different country who is never going to be paying taxes toward that cost? Are you the healthcare system, the healthcare leader who is going to pay the costs for that MRI, but is not paying the costs of the patient who has to transport themselves to the hospital, get childcare, and navigate feeling having an allergic reaction to the IV contrast from the MRI afterwards, right? So all those individuals have different perspectives, and so typically in cost effectiveness analysis, you want to be very explicit about your perspective you're taking. So common perspectives that people use are kind of a healthcare sector perspective. So it's that health decision maker who's thinking, how much does my clinic have to pay for this? And then there's often the societal perspective. So most standards for cost effectiveness analysis encourage us all to include a societal perspective plus one other relevant perspective. And so for most of my work, these are the 2 I use, healthcare sector perspective and societal perspective. And essentially the difference is, what does that health system have to pay? In the societal perspective, we're incorporating other things like those patient level costs that impact the society. Missed work days for your patients or childcare costs, like all of those things that that would not show up in just a healthcare sector focused perspective. Before kind of guidelines and standards for cost effectiveness analysis emerged, people didn't specify. And so it could be impossible to compare across studies because if you don't know if they included patient level costs or they did, that drastically changes how much you can compare to studies. And so I think this is a really important thing. So the second US panel on cost effectiveness, there's actually like a textbook from these guidelines, but there's a nice summary by Sanders et al. That's just a more digestible publication in JAMA that summarizes recommendations around cost effectiveness analysis. But one of their recommendations is for all studies to include an impact inventory template, which specifies your perspectives. So you see those column 3 and column 4 are showing like an example of a healthcare sector perspective and a societal perspective, and just a checklist of what did we include, what costs did we include in this in our inventory of costs, so that if you're comparing one study, my study to your study, you can quickly look and see what did I include, what did you include, and those comparisons become easier. One thing I'll say is perspective versus retrospective cost estimation. So my very first cost analysis was my mentor, I think at the end of fellowship, mentioned that she'd been meaning to do a cost effectiveness analysis on her trial, but no one was available to do it. And would I be interested? So that conversation happened as the trial was ending. So that meant what? Our cost estimations had to all be retrospective, right? So it's not the ideal as with any data collection. You ideally want to do prospective data collection as the study is ongoing. But certainly lots of studies do what I did, where you do interviews and kind of collect, you look at meeting notes and budgets, and you look at people's consulting bills, and you collect data from various sources and you put together estimates of costs. But ideally, prospective cost collection is going to be better. Thinking in our collection of costs about Hawthorne effects and observer bias. So when you watch people and you track people, they might behave differently. And if your costing strategy is intensive enough, it actually might be part of your intervention or your implementation strategy, because if it's intensive enough, it gets into the category of process monitoring and potentially even audit and feedback. So just be mindful of that. And then multi-methods or mixed methods, kind of surveys, interviews, time studies, lots of different methods could be used. And then how do we communicate these things? How do we both communicate them back to our, like in terms of a member checking back to the people that fed us the information? How do we use tools? I've had success with both kind of cost narratives, which are just, couple page documents that sort of narrate like what were the big components of costs and what went into them, or kind of using tables that are more summative. And that is a great communication tool to kind of come back to the team and your implementers and say, these are all the things that we're including in our cost estimations. Here's our summation, like what we thought everything costs. These are our sources. What do you think? What's missing? What did we get wrong? Does this have face validity to you? And then those tools also become great things to include in your papers as either supplements or can kind of be converted into primary tables. So take-home points. Effectiveness is necessary, but not sufficient in terms of getting evidence-based practice into common practice. Costs matter in a world without unlimited resources. Whether you propose an economic evaluation depends on the state of the evidence regarding efficacy and effectiveness of your intervention or program. Doesn't make sense if you're at the efficacy stage or early effectiveness stage to really be tracking costs, because your intervention's morphing and adapting, and you really don't, I don't want to see people wasting resources on a economic evaluation in early stage research. but sort of the later stage kind of hybrid type 2, hybrid type 3 to implementation type studies is where economic evaluations, I think, are most helpful. And then keeping in mind that rigorous costing can actually be resource intensive. So it's helpful to engage a health economists. I've heard people say even, an accountant could be a really helpful member of your study team. Oh, okay. I think we call them accountants in the US. So thank you for that clarification. Okay. So implementation studies should ideally include a budget impact analysis aim if there's any doubt about availability of sufficient resources for scale out. So the pro of that is understanding investments needed to help decision makers assess feasibility. The disadvantages are that budget impact analyses can results can be more difficult to publish. They are a little bit more difficult to publish in peer-reviewed journals due to generalizability concerns. They're, as with any kind of descriptive study, can be sometimes difficult. If there's any reason to believe your intervention or program will be more costly than usual care, then a cost effectiveness analysis or cost benefit analysis may be appropriate. The advantage of that is the expected value of interventions can help make the case with policymakers or payers that your intervention should be adopted and covered. The disadvantage is that meaningful effect and benefit assessments may require advanced simulation modeling, which is even more resource intensive. So what do I mean by that? Who's familiar with simulation modeling? I think it's come up in prior talks. So why might we want to do simulation modeling in our cost effect instead of just kind of taking our cost and dividing it by our effects? What are the cases we might want to do some simulation modeling in cost effectiveness analysis? Okay, say more. What do you mean? Mhm. Okay, yeah, so you might, right, so sometimes, I think what you might be getting at is sometimes you can't do the trial you ideally want to do because of ethical reasons or various other limitations. So sometimes simulation can allow us to, it wouldn't really be ethical to, once you've done your efficacy, your effectiveness trial, it wouldn't be ethical to use resources to do like a national level randomized trial with a placebo arm because you already know that it works. So the equipoise isn't there to justify kind of not doing it for half the population. So simulation can allow you to sort of think about how does this work for then, how would this impact a broader population? What would our costs look like? What would our kind of more national level or international level impacts be? And simulation can help you do that. Okay, what else? It's as good as the data you put into it. So there's the whole garbage in, garbage out. So you're feeding the simulation model the parameters of the simulation model. So if the parameters are solid and grounded in a lot of evidence, then you feel good about it. Excuse me? They should be, but sometimes you don't know, and we can talk a little bit more about that. But that's where you get into uncertainty. Some of your parameters are going to be more consensus. Some of them are going to be grounded in solid evidence, and so there are approaches like sensitivity analysis or scenario analysis that allow you to kind of explore how much that that uncertainty actually impacts your conclusions. So we all like worry a lot about uncertainty in our estimates, but sometimes that uncertainty doesn't matter. And I think that's been what's so fascinating about this field. There's actually an approach called value of information analysis, where you can see if this parameter, like for example, the cost of physician's time or something like that, like if your estimate of that is based on just your guess, you can do some sensitivity analysis to give a wide range. And then you can do an analysis that can tell you, like, how much does this matter? Does it really matter in your ultimate decision of does intervention A, is it more cost effective than intervention B? In some cases, the thing that you're worried about, you have uncertainty around, doesn't actually impact your ultimate decision. So it doesn't make sense to spend any resources to try to figure out that uncertainty. But that also is a whole nother talk. So I'm just going to cut to the chase with the simulation modeling. The other advantage is, as a pediatrician, I worry a lot. If we just look at our cost effectiveness over the next year, for example, for an intervention for children, we're going to be limited, right? Because a lot of what we do in childhood, it's not realized till the benefits aren't realized till children are much older. So with simulation modeling, we can kind of bring together data from different sources, and we can ask questions like, if I reduce this child's BMI by 1 unit at age 6, based on all of the data we have about long-term effects of BMI, what might be the impact in 10 years on their quality of life? So that simulation allows us to do that. Otherwise, what would we have to do? We'd have to do a 10-year-long randomized control trial with immense resources. So there's a lot of power and potential to that, but also a lot of caveats, because garbage in, garbage out, and the parameters have to be based on meaningful information. So remember that cost effectiveness analysis is always relative to something. Though that's a point I want you to definitely take away. Perfect. I have 5 minutes. So I added some, we talked a little bit about simulation modeling and its benefits. I thought you guys might be interested in just a case example of two studies from my work where we use simulation modeling to kind of get at what are the benefits of our obesity interventions over a longer time horizon. So this is a group choices out of the Harvard School of Public Health, which is where I did my training and kind of was on faculty for my first few years. So I collaborated with health economists and simulation modelers in this group to project, this clinical decision support intervention that we did in these clinics in the Massachusetts area. What would that look like if we spread and scaled them? And I mentioned this study earlier, but just to give you a sense of like how the model worked. Yeah, when you do simulation modeling, you essentially, in the approach that we took, you essentially try to simulate a population. And so in the US, we have census data. So we created a virtual population of patients. We characterized that population with features like growth trajectories and BMI trends based on nationally available data. We gave them some individual factors. So, they had differences in how their bodies were going to grow over time, and they had differences in personal characteristics. Some might smoke, some might not, those sorts of things. And then we started the time horizon, right? So we started in year 2015, and this population sort of did what they were going to do, almost like their, the simulation games that folks might play. They went along their trajectories, and then at some point they might have interacted with our intervention. And then we sort of at the year 2025 in our simulation, we assessed their outcomes. We saw, what was the intervention's impact on things like obesity, healthcare costs, and mortality. And so what's great about partnering with this larger group, they were concurrently doing simulation studies on all sorts of other preventive interventions for obesity, as well as things like bariatric surgery. So when I published our paper, I'm going to skip over some of this, I was able to contextualize our results in comparison with other interventions. So for example, what would the impact be of having a sugar sweetened beverage tax? Huge impact on cases of obesity prevented, huge costs as well, but the cost savings are substantial. And so they kind of offset those cost benefits. Restaurant menu labeling, after school programs, making them healthier, having smarter snacks at school, impacting advertising, like all of these other interventions. And so you'll see the box around kind of bariatric surgery and our electronic decision support intervention, we were able to kind of place those in the context of all these other things. And you'll see our impacts were underwhelming in terms of being able to impact obesity prevalence. And anyone who studied public health could have predicted that, right? Like the high risk strategy is never as impactful on prevention as the kind of universal strategy. But we have a high prevalence of children who already have obesity, and we need to offer them treatment. So kind of having some points of comparison in terms of what are the net costs and what is our projected impact was just a really, really interesting study. And I'm sorry, I'm going through this kind of fast, but the other thing is, much of our discussion has been around our primary care-based intervention that's really sort of brief and focused and has a small impact on BMI, children's BMI. The evidence shows us again and again that it's really high dose, high intensity interventions that make a difference for children with obesity. And the US Preventive Services Task Force has put out recommendations 3 times since 2010 saying that these high intensity family-based behavioral interventions are really where effective treatment happens in a clinically meaningful level. So that has become a little bit more of where I'm focusing attention. And so when I got to Yale, I was excited to meet with folks who had done one of those early trials that informed those recommendations of the US Preventive Services Task Force. It's an intervention called Bright Bodies that takes a family-based, non-diet, healthy food choices and lifestyle approach. And so I got to Yale and I learned, they published their trial in JAMA in 2007. They got a lot of attention around this intervention. The dietitian that developed the intervention packaged up her intervention into a curriculum and shared this intervention with over 30 sites across the US, plus sites kind of internationally. And the implementation scientist in me got so shocked, but also kind of excited to learn that no one had looked at that. There was no follow-up to see what happened at those sites. Did they actually implement? If they implemented, were they successful? So we wrote a grant, and we fortunately got funded to be able to kind of both do some retrospective work looking at what happened at all those sites to do our formative evaluation, and then we optimized the intervention using some of the user-centered design principles that we talked about earlier. And now our trial is underway at 3 new sites that represent kind of different populations impacted by obesity disparities to see if we can kind of move the needle on better implementation and better effectiveness. But what was so disappointing and shocking from our AIM-1 was that all these 30 plus sites we reached out to, very few successfully implemented. And of those that implemented, only 4 were able to sustain up until the pandemic. And then post-pandemic, 1, the original Yale program. So, heartbreaking. And the main driver we found kind of gets back to your question was financial. The main driver was finance and staffing. And so that prompted us to use cost effectiveness analysis to try to advocate for better funding for these evidence-based programs that have been strongly endorsed by guidelines for the past decade, nearly 2 decades. So we completed a cost effectiveness analysis of the Bright Bodies intervention using cost data that was collected during the original trial, but no one had ever done anything with. And we used simulation modeling to sort of project out over 10 years, what did we think would happen? And compared it, so the neat thing about the original trial was it was an intervention in comparison with standard of care. So it wasn't do nothing. It was actually, see a specialist and kind of have a 6-month visits. So that had costs. And so we were able to compare the intervention to the usual care, which was actually costly visits with a specialist. And so my last point, I promise. Yes, this is my very last point. So the punchline from this was that we set this analysis up so we could estimate how long does it take to get to cost savings. So this figure actually shows, the costs of the intervention in comparison with the kind of standard of care comparator. And we showed that within 3.5 years, you get to cost savings. And the reason why that's so important is because in the US, most insurers are really focused on like 5 years because they're going to lose you after that. And so that ended up being really exciting. And it's led to a lot of kind of discussion with the CDC and the AAP and kind of part of their efforts to create procedural codes for intensive lifestyle interventions to allow for better reimbursement and overcome some of those financial barriers. So I did promise that was my last point. So,
You don't